Uh, Good evening, all members of TRIOGS. Welcome to our monthly meeting for January 2022. I think you all had a nice Pongal and good celebration, Jallikattu and all that at home. Unfortunately, this event was planned as a physical meeting on 15th of January to celebrate Pongal in all colors and this thing. But because of the third wave, we had to convert this into an online meeting. So welcome everybody to Thai Masam, and today we are going to have a very nice session on RH Rhisoimmunisation. Thanks to BSV for organizing this program and for providing the webinar and the digital platform for this event. We have very good speakers for today. I request our President Dr. Malti Prasad to give a welcome note.
Good evening, everyone. Hope all of you are keeping staying safe in the pandemic. And as Deepa said, we were planning for a physical meeting, but could not because of to consider the safety of everyone who's coming. We have a very interesting session on RH immunization. Even at the in spite of vigorous use of anti-D, we still have a lot of cases presenting with fetal anemia and immune hydrops. So, of course, the ratio between the non-immune hydrops and immune has gone down, but still, we still see cases of immune hydrops. So, where are we going wrong? What is happening? So, are we not doing enough? Anti-D for rhisoimmunisation. So a lot of discussions on that. We have a very interesting speaker, Dr. Prabha, who's the Associate Professor of Tanjore Medical College, who will talk to us on the role of RH immunization and sensitising. And following that, we will have a case discussion by Dr. Sudha, and following a few case interactions based on eye drops. So I request Dr. Deepa to introduce a speaker, Dr. J. Prabha.
Thanks, Malti. As Malti has rightly pointed out, RH rhisoimmunisation is a completely, or at least most often, a preventable thing. But we are in fact seeing more and more cases. I think Dr. Malti and Dr. Sudha, both fetal medicine specialists, are really into this management of this condition. And so that's the reason why we have invited them to share their experiences today. Somewhere we are going wrong, and we need to find out where we are going wrong, and we have to be proactive in giving anti-D as far as possible, the correct dose at the correct time, and everything is what, and everything matters as far as RH rhisoimmunisation is concerned. So we start with today's program. I request Dr. Prabha, J. Prabha. She is a very active member of TRIOGS. She is an associate professor at Tanjore Medical College, a very good teacher, in fact. And an all-rounder, I should say. She has actually participated in one of our cultural events a couple of years ago in a skit program. Is that right, Shubha? Prabha?
Yes, ma'am. Still, I've got the videos about.
Yeah, she was a very active participant in one of our cultural events, and she's an excellent teacher. She's a consultant at WellCare Hospital. So Dr. Prabha will be presenting a lecture on RH rhisoimmunisation, sensitizing events. Over to you, Dr. Prabha.
Okay, very good afternoon. Very good afternoon to all the members over here. First of all, at the outset, I thank our Dr. Deepa for giving me this opportunity as the first lecture for the start of this academic year. Very nice to meet you all through this platform. Thank you so much.
Dr. Prabha is going to be our executive committee member for the next team as well.
Thank you so much, Deepa, Dr. Deepa. And we are going to the slides. So the RH immunization, as we all know, we have studied in the UG level and PG level. We all know that just the how to prevent anti-D. So 300 microgram of anti-D given within 72 hours after the delivery will prevent the whole sort of events. That is a simple thing. But 50% of the Indian population are still not able to get the anti-RH, and still our India, we are suffering from, although we are in a good developed state in Tamil Nadu, still there are states where there is no supply of anti-D. So we'll go through all this in a rush. Actually, we all know this. today it's going to be all a recap of the same what we have studied in the PGs and UGs level. Ma'am, excuse me, ma'am. All the slides have been crumbled, jungled. 1 minute. So this is the first one. So as we all know, what is isoimmunization? It's just the production of immune antibodies in an individual in response to an antigen, that is Rh positive, derived from another individual of the same species. So what is Rh incompatibility? It's condition where the pregnancy, the mother has Rh negative, but the baby is Rh positive. So isoimmunization is nothing but accelerated antibody production in response to fetal RBC's Rh antigen when the mother is Rh negative and she carries a positive fetus. So here in this picture, we clearly see the mother is having Rh negative blood group, the baby is being Rh positive, and through the transplacental bleed, the Rh positive cells being entered into the mother, and the mother has started antibodies that is going to cross the placenta, and that unanimously affects the second pregnancy if nothing is being given. So it is being done. Isoimmunization is being occur in 2 stages. One is sensitization. Sensitization is nothing but the first pregnancy, just the antigen Rh positive that is being in the fetus has entered into the mother's circulation and has just sensitized the mother's immune system. See, some foreign has entered through, be alert. So that is the first thing that occurs. Usually the first baby escapes because there is no production of antibodies. And also, provided there is no major factor like any previous blood transfusion or previous trauma or anything else in the mother. So this is the very first event. The second event is the immunization. After the birth of the baby, already the Rh positive that has entered into the mother's blood has initiated some immune response in the mother. So the mother starts some amount of antibodies. When the second baby is also becoming positive, the active and robust production of antibodies will be there, and that will cross the placenta in a gush in the second baby and will destroy all the Rh positive RBCs in the blood of the baby if the second baby is going to be positive. So that is immunization. So in this picture, you are able to see the antibodies that have been crossed into the placenta and produces robust immune response, and thereby a lot of antibodies that is being ejected from the mother to the baby, thereby destructing the baby's RBC. So in this picture, we'll see the couple here. The father is Rh positive, the mother is Rh negative. They conceive the first baby. So Rh antigens from the developing can enter the mother's blood during pregnancy. This is the high risk factor over here. So in the subsequent pregnancy, already the mother is being sensitized now. In the subsequent pregnancy, for example, in the second time she conceives, again, it is a positive pregnancy. That is, the baby is Rh positive. Again, the RBCs that have been produced in the baby crosses the placenta and produce immune response that is very alarming. And these are the green things that are the anti-Rh antibodies that crosses the placenta, usually in the last trimester or at the time of labor, and it produces destruction of the antibody, destruction of the RBCs, the baby. According to the severity of destruction, the baby will be affected. So here in the picture, father is Rh positive, mother is Rh, and fetus is Rh positive in the first pregnancy. Now, repeat encounter in the second baby, rapid production of IgG. Now, IgG will cross the placental barrier quickly, and they in turn go and affect the baby and marks the fetal blood cell for destruction. And eventually, fetal red blood cells, the second baby, if the second baby is positive, becomes destructed, and the baby will go for, according to the severity, the baby in mild cases will have mild anemia and jaundice. In severe cases, the baby will have kernic stress and all sorts of events. So again, it's a pictorial representation. The first baby, the first child is unborn. The first child is born unaffected because the fetus and maternal circulation are separate, and these RBCs are crossed during the time of the labor, usually at the time of the labor, there will be transplacental bleed, which is maximum, and hence the antibodies that are produced against the Rh positive will be there. In the second baby, this antibodies will coat the Rh positive blood cells in the second baby, and it will mark for further destruction from the mother. So the causes and risk factors for Rh incompatibility. Before exposure to fetal Rh positive blood occurs at maximum at the time of delivery. Threatened miscarriage, trauma, external cephalic version we do for the breech presentations, and invasive procedures like chorionic villus sampling, amniocentesis, which will cause significant fetal-maternal bleed. If taken in expert hands, it will be very minimal. Ectopic pregnancy, molar pregnancy, antepartum hemorrhage, where there will be a result of a lot of fetal-maternal bleed, where placenta previa and abruptio, vasa previa, and of course uterine rupture, still not very uncommon in our country. So the non-fetal exposure to Rh positive blood results from transfusion or bone marrow transplantation to the mother or any needle stick injury. So the fetal-maternal hemorrhage, what is that? Already we have explained at the time of the labor, the blood from the fetus enters the maternal circulation. That is called FMH. So moderate to severe FMH occurs in about 0.3% only of all the labors. And we have to remember, in all the 96% of the women, the average FMH occurs during delivery is only less than 1 ml. So we are giving 300 microgram of anti-D that is able to neutralize 15 ml of 15 ml of fetal RBC. So just imagine we are giving more than the enough dose, which will sufficiently abort all the immunogenic response in the mother. So if there is entry of fetal blood into the maternal circulation before or during delivery, where there is extra loss of fetal-maternal hemorrhage more than 30 ml, and that is up to 1% of the pregnancies. So 96% there is just 1 ml. Only 1% will be having more than 30 ml of the fetal-maternal hemorrhage. As we have already discussed, in placenta previa or vasa previa or severe hemorrhages the mother may face. During pregnancy, 10% or delivery, sometimes in some cases 90%. 99% of the women have fetal-maternal hemorrhage of less than 4 ml. Usually in the first trimester, 3% may occur, and second trimester, the chances are 12.1, and in the final thing, it is 45, and after delivery, it is 63. So sometimes silent FMH may also occur. So we have seen a lot of number of cases where there are, without any significant causative factor, there will be some the rosette formation in the second baby. That is due to silent FMH. So again, in the first trimester, the chances are 6.7, and actually the volume is 0.07. Second trimester, it is 13.9, and the volume is 0.08. And the third trimester, it is about 29% roughly, and the volume counts to 0.13 only. In the delivery only, it occurs maximum 76 FMH. That will result maximum less than 0.19 only. So we have already told 96% of the women, the fetal-maternal bleed will be maximum in the delivery, that will count to only 1 ml. So the risk of sensitization also depend upon the quantity of the leak also. So if it is 0.1 ml, it is 1%. It is 0.5 to 1 ml, 25%. So we are here where 96% of the women, if it is, it will be less than 1 ml. So our cases are exposed to this 25% of the chance. So more than 5 ml, in some cases, it results almost in 65% of risk of sensitizing the mother. So how to find out how much amount of fetal RBCs has entered into the maternal circulation? So the first and foremost test is the Kleehard-Bethke test. That is otherwise called acid elution test. So here we measure the amount of fetal blood in the maternal circulation. This is the slide where we are treating the maternal blood, which is being fixed with 80% ethanol. And after staining with hematoxylin and eosin, we are seeing it in the low power microscope where the RBCs of the fetal blood cells are seen bright red, because this is due to the hemoglobin F, which is resistant to acid, and hence it won't be eluded by acid. Whereas the maternal cells will appear as ghost cells because they will be destroyed by 80% ethanol. So here we are going to count the number of RBCs, fetal RBCs to the total amount of maternal RBCs. Thereby we can come to a conclusion, total amount of approximately the amount of fetal-maternal bleed that has happened. So the number of fetal cells divided by the total number of adult cells is equal to the number of approximately the fetal-maternal bleed that has happened. So another test is that if we detect greater than 2 ml of the fetal whole blood, then the Rosette test will become positive. The Rosette test is nothing but we have to incubate the maternal blood sample, which RH immunoglobulin, and there fetal RH positive red blood cells will bind to the specific indicator cells we are adding to it. So those will form as rosettes clearly. So if rosette formation is seen, it is indicating that fetal-maternal hemorrhage is more. So coming to the postpartum prophylaxis, just imagine if we are not giving any postpartum prophylaxis with anti-D. So first one will be escaping. The second one will almost, as we already have discussed, 25% will be affected because our range 25%, less than 1 ml in 96% of the females, where that will almost result in hemolytic disease of the newborn, which will result in the various sequelae for the second born baby, severe jaundice, erythroblastosis, kernicterus, and the baby will be bloating in the fluid, that is high drops. So if the mother is not being given with anti-D prophylaxis, the incidence of sensitization is as high as 12 to 16%. So these are the X-ray appearances of the baby with hydros fetalis, halo, round head due to edema of the scalp. The accumulation of fluid is around every other organs of the fetus, splaying of the ribs due to the enlarged liver and spleen, hepatosplenomegaly, liver cardiac failure, abduction of the limbs that the baby will attain a Buddha attitude, and there is a flexion due to enlarged abdomen. And kernicterus, as we all know, the accumulation of escape of the bilirubin, excessive bilirubin in the blood-brain barrier of the baby and deposited in the basal nuclei of the fetus, and resulting in various degrees of severe mental retardation and sometimes, and most often lead to death. So coming to the disease burden, the globally 7.2% of all the disease affected who survived developed kernicterus. And neonatal death due to RH disease worldwide is 24%. In India, it has been estimated still 50% of the people won't have the access to anti-D immunoglobulin 72 hours after delivery. So now imagine we have given the anti-D immunoglobulin within 72 hours of delivery, and now this anti-D protects the baby from the immunization being happening, and as a result, the second baby will be not affected and the baby will be free of any sequel. So the risk of immunization is reduced to 1.5% in case of the patients or the mothers who have been immunized with anti-D within 72 hours of delivery. So coming to the mechanism of action of anti-D in preventing the isoimmunization. The anti-D, once we give within 72 hours, it rapidly clears the RH positive D cells, whichever has escaped from the baby to the mother. And the epitope that is being expressed in the RH positive cells of the baby, the anti-D which we are giving mask the epitope. Thereby, it ultimately and completely prevents the immunogenic potential, that is immunogenic awakening of the mother. So the mother won't have time to won't have time to sense that something foreign has entered into the circulation. So the immunogenic potential won't be there in the mother. Completely it masks. And the other postulates how it inhibits is inhibition due to antibodies against the specific receptor for Fc fragment of IgG, and inhibition of immature dendritic cells. Of all these mechanisms, the accelerated destruction of D positive cells from the baby is the main mechanism postulated for the action of the anti-D. So anti-D immunoglobulin, if given within 72 hours, will completely stop the Rh positive antigens from being stimulated and to going on attaching to the immune system. If antigens are neutralized, mothers won't produce antibodies. Now coming to the anti-D prophylaxis in sensitizing events. Anti-D immunoglobulin is given to the women to prevent her producing antibody against anti-D positive blood cells, thus preventing development of the HDN in an unborn baby. So it is usually extracted from the plasma of the donors having high circulating anti-D. It is usually given intramuscularly and sometimes intravenously. Here we usually give in the deltoid region. Development of the anti-D antibody usually occurs as a result of FMH in a negative with the Rh positive. It should be as just the repetition. 72 hours it should be given, or sometimes if we miss the 72 hours, it can be given within 10 days also. It has got some effect, but at the maximum it should be given within 10 days. The best route is deltoid. And the last point is women already, if it is being sensitized, anti-D is not indicated. So let us come see what are the potentially sensitizing events in less than 12 weeks, where the dose of 50 to 100 microgram is enough. Significant bleeding during threatened abortion, spontaneous miscarriage, medical termination of pregnancy, surgical termination, ectopic pregnancy, and vesicular mole. So here, most of the gynecological association, obstetric and gynecological associations advise 50 to 100 microgram to be given after the sensitizing event within 72 hours. So here are the special things where embryo reduction, abrupt show placenta, chorionic villi biopsy. Here they recommend some higher amount, 10 microgram of the additional dose to be added for every 0.5 ml of the fetal RBCs, like blunt trauma, intrauterine death, and external cephalic version, and placenta previa with bleeding. So the fetal-maternal hemorrhage leads to sensitization of Rhd negative mothers, resulting in an increased risk of hemolytic disease. Such events cause FMH are called sensitizing events. Already what I have told you is the same repetition, 6.7, 13.9. The amount needed for sensitization is 0.1 FMH ml and 0.5 to 1 FMH and more than 5 FMH per ml. So how to screen these mothers? The first thing is the indirect Coombs test to detect Rhisoimmunisation before delivery. Direct Coombs test after delivery, it is done usually in the cord blood. So indirect Coombs test, the procedure is to check whether the mother is sensitized or not. 5% of the saline suspension of the positive red cells are incubated with mother's blood at 37 degrees for 1 hour. That is being washed 3 times in saline, Coombs serum added and centrifuged, checked for agglutination. If agglutination is present, then ICT is positive. Already mother is sensitized and no need for give for anti-D. Most of the thing we are going to protect the mother. So our mothers will be always ICT negative, not sensitized. Hence, we can give anti-D prophylaxis. So this is the algorithm. Mother is Rh negative. Antibody screening should be done at the following intervals: 20, 24, and 28. Rule out any silent FMH that have occurred. So if it is negative, no problem. We can administer 300 microgram of immunoglobulins at 28 weeks. At delivery, the newborn Rh status of the newborn should be checked. Again, if the newborn is Rh negative, no need for anti-D. And if the baby proves to be positive, we have to give 300 microgram of anti-D within 72 hours of delivery. So if the maternal antibody screening becomes positive at any point of time, we have to manage the pregnancy as if it is a Rh sensitized pregnancy with the help of a neonatologist and all our Dr. Maladi Prasad and our experts over there. Amniocentesis, the next step is amniocentesis are estimation of fetal bilirubin levels and optical density at 450 nanometers to be seen. And further management depends upon the severity of the erythroblastosis. percutaneous umbilical blood sampling, amniotic fluid analysis, ultrasound examination, and Doppler. So, anti-D is an antibody against E epitope present on the fetal RBC to prevent mother from sensitization. As we have already discussed, its main mechanism is accelerated destruction of the that is Rh positive blood cells that has been escaped from the baby to the mother, thereby preventing the mother's immune response to prevent antibodies. And 300 microgram approximately neutralizes 30 ml of fetal Rh positive and 15 ml of packed RBCs. So the available anti-D are monoclonal and polyclonal. So what are the various guidelines? So universally, all these committees, American College, Royal College, FOXI, our Indian FOXI, and a British Committee for Hematology, NHS, Canada, and Australia, they all recommend universally within 72 hours as a postpartum prophylaxis 300 microgram. The dosage don't change in all these communities. Only in case of sensitizing events, the dosage varies from society to society. We'll see all that. In ACOG, less than 12 weeks, it is 50 to 120 microgram. More than 12 weeks, they directly advise 300 microgram. In RCOG, within 72 hours, less than 12 weeks, only for ectopic, molar, heavy intrauterine bleeding, they advise 250 international units. If it is 12 to 20, 250 and more than 20, directly they are going for 500 international units. In FOXI, 300 microgram in postpartum and 50 to 100 in the sensitizing events. In British Society for Hematologists, they recommend less than 12 weeks, ectopic, molar, heavy intrauterine bleeding, 250 units. If it is 12 to 20, 250. More than 20, they are also going directly for 500. In NHS London, they recommend 500 units for all the sensitizing events. In Canada also, they recommend 120 units in less than 12 weeks and more than 12 weeks, 300 microgram. In Australia and New Zealand, in the first trimester, 250 international units, second and third trimester, they recommend 625 international units. So, what is our guidelines? ICOG FOXI recommends 50 to 100 microgram as an anti-D injection in the first trimester and 300 microgram for all those in the postpartum. So, the dosages available in India are 150 and 300 micrograms. In case of suspected high fetal-metal hemorrhage, higher doses of anti-D can be given. Higher doses won't produce any harm to the mother. So coming to the production part, how anti-D is being produced. Here, we have got a human donor who is being hyperimmunized with Rh antigen. Side by side, we are having myeloma cell culture also. So we are growing the myeloma cells also continuously side by side. We are injecting the anti-D producing lymphocytes and we are mixing both and producing a fusion. So this results in a hybridoma, monoclonal anti-D. And after the cell culture, we are able to produce clear, purified human monoclonal antibody, which is very safe for the usage. Now, how to produce recombinant anti-D? In the hybridoma state itself, the gene is being spliced and it is being injected into the Chinese hamster ovary cell line, which is being transfected with this gene, and thereby it will be multiplying in that CHO cells. And after that, which is being purified, anti-D from the CHO cell will be harvested, which will result in pure and recombinant anti-D. So both are safe. So coming to the monoclonal antibody, highly specific antibodies against single antigenic epitope is being produced by a clone of a single hybrid cell. Advantages are very specific, consistent, uniform, and safe for transmission. So what do you mean by polyclonal? Nowadays, we are not using this polyclonal. It is usually derived from sera of the immunized humans. It is made by mixture of antibodies with affinity for a wide range of antigenic epitopes. It is difficult to manufacture in large quantities and difficult to provide consistent batches because the human may vary from the batches may vary according to the person to person. Chances of transmission of infection and harmful proteins are there. So we are going for either monoclonal antibody purified human, roclone, or recombinant antibody. So just the comparison, monoclonal is greater and consistent, and specificity is very high in monoclonal. Half-life is 23 days, whereas it is 15.6. It is very highly purified. Polyclonal, it contains some antibodies and plasma proteins. Batch-to-batch variation won't be there. Here will be variable. No risk of transmission here. Some types of prion-like diseases will be transmitted in polyclonal. Unlimited supply can be done. It will be limited because the human sources won't be available at all times. So coming to the trials, they all recommend, the study all recommend universally monoclonal anti-D immunoglobulin is more effective in the prevention of sensitization. A lot of studies are there. Due to time constraint, I am restricting to just 2 studies alone. So coming to the RH isoimmunization, we have to screen all the mothers for blood group. Screening of antibody for RH negative mother to be done at 20, 24, and 28. And accordingly, we have to manage. At the 28th week, we are supposed to give the anti-D 300 micrograms in the mother if she is not being sensitized. And after delivery, within 72 hours, we are to give 300 microgram of anti-D immunoglobulin to the mother. After sensitizing events, within 72 hours, depending upon the type of the sensitizing events. So coming to the summary or take-home message. So prevalence of RH positive population in our country ranges from 5 to 15. RH negative mothers bearing RH positive has a very high chance of developing antibodies. RH positive fetus born to sensitized RH negative have high risk of developing hemolytic disease of newborn. Sensitization in RH negative mothers can be prevented by anti-D prophylaxis in the postpartum period, as well as in the sensitizing events such as abortions and lot number of procedures like amniocentesis, chorionic villi biopsy. Monoclonal anti-D preparation offer advantages of specificity, uniformity, consistent, and safety. Management of sensitized RH negative require frequent monitoring and expertise of intrauterine blood transfusion. So coming to the fag end, I think, thank you so much for the patient listening. Over to Dr. Deepa.
Fantastic presentation, Dr. Prabha. I think that was crystal clear. We got a very nice recap of what is sensitization and what is immunization and how to prevent isoimmunization. I think the culprits are, I think postpartum immunization most people are doing. Yes. But the culprits are probably abortions and
yes,
silent. I think for abortions, nobody is even doing a blood group before doing abortions. I think that's a very important thing. And even postpartum, I think people who are undergoing sterilization, they are not receiving anti-D. There is a case where they can have some kind of need for blood transfusion later on in life, such as a road traffic accident or something, which when they require blood, there can be sensitization. So I think all mothers need to be given anti-D, whether or not they are undergoing sterilization. That should be the dictum. So very nice presentation. I think we have seen an overview of, please, Malti. Yes.
I think it was a fantastic talk, Dr. Prabha, very well done. I just wanted to add something for the benefit of our members. The first important thing, indirect Coombs test. Very often when the indirect Coombs test is positive, we get a frantic call from the consultant saying that ICT is positive, the baby is likely to have fetal anemia. And the ICT is titers positive or negative. So just doing the titers is not enough. We need to do the levels and positive, negative is not enough. We have to do the titers because only then we will know the critical titers. So levels more than 4. Suppose it's
yes, ma'am. I put the slide. It didn't come out. 1 is to 4 is suspicious. 4 to 8 is sensitized.
I wanted to tell something about the laboratory thing which happens. If it is 4 to 15, we say it's moderate anemia. More than 15 is severe. When it comes to the titers, for example, when you have IC, you've done the IC. When we have ICT positive, we'll tell the patient that please do it in titers. When they do it in titers, please check the laboratory or ask the laboratory personnel what type of method it has been done. Whether it has been done by a conventional tube method or by a gel method, because there's a difference between the critical titers with the tube method and the gel. Both are agglutination. It's done by two different methods. For example, if it is done by a conventional tube, if it is not mentioned, usually it's mentioned in the report. If it is not mentioned in the report, please call your laboratory and ask them what method it has been done. If it is done by the tube method, the critical titers will be 1:16. If it has been done by the gel method, the titer will be 1:64. For example, if it's done by the gel method and it has not been mentioned, so the patient has an alarm, it causes a lot of anxiety to the mother, to the consultants, patient coming far off, and you keep tell the patient that come for a weekly peak systolic velocity of MCA. So it causes a lot of anxiety, cost, all that adds on. So always important is that when you have a tube method, take the critical titers 1:16. When you've done a gel method, take it as 1:64, because when we see a 1:64, there's a panic among all the patients, anxiety. So always ask the laboratory whether it's done with the tube or gel method. And if it is done by the international units per ml, make sure that if it is 4 to 15, you can take it as moderate anemia. More than 15 would be a severe anemia. I think rest of it, as we go on, we'll have a lot of discussions. So this, always ask your laboratory personnel what method it has been done, so that it helps you make a judgment and assessment whether the patient needs to come every week or once or 2 weeks, so that it causes undue anxiety to the parents or to the consultant. And need for transition also can be discussed based on that. Thank you. Thank you, Dr. Prabha.
Thank you, madam. Thank you for adding, madam.
Yeah,
More
thanks.
practical points.
Yeah, these are two few practical points which we tend to ignore. And it's important that everyone knows
Definitely.
that at that point, when you do an IC titer, immediately you call the lab and ask what type of method it has been done. So it becomes easy for you to follow up the patient.
Yes, definitely, definitely.
A very valid point Malti has mentioned. Thanks, Malti, for that nice input. I think to go ahead with how to deal with such sensitized or immunized mothers, we have experts, Dr. Malti Prasad and Dr. Sudha Ramakrishnan. Dr. Sudha is going to present some interesting case for us to understand and discuss further. Dr. Sudha Ramakrishnan is a very well-known fetal medicine specialist and practicing in Trichy. She was the first fellow to come out of Mediscan systems, and she is one of the executive committee members of AICC RCOG Tamil Nadu chapter, and a very dedicated worker. She's an MRCOG as well. Welcome, Sudha. I think we go on to Sudha to present some interesting cases, and Malti will also be there to give us extra inputs, and we go ahead with the discussion after the case presentation. Over to you, Dr. Sudha.
Thank you, Dr. Deepa, for the kind introduction. As a sequel to Dr. Prabha's presentation on RH isoimmunization, I have 3 cases to discuss, each with a different perspective. So let's move to case number 1. She's a 30-year-old gravida 6 para 5 with 2 children. That is, she had a twin pregnancy. She was an RH negative gravida, ICT positive.
Can you start sharing your screen? You have it on your PowerPoint, right, Sudha?
Is it not visible as yet?
No.
1 second.
Go to share screen and then open your presentation on your desktop. Yeah.
Is it visible now?
Yeah, it's visible. You go to slideshow.
Okay. So
Fine.
now this
Yes.
is case 1. This is CA 30 years, gravida 6 para 5 with living twin children. She's RH negative, ICT positive. So she had twins from her first pregnancy, delivered preterm, and then both babies are alive and 11 years old when she had come to me in 2015. So anti-D was given post-delivery. Followed this, she had 4 pregnancies with hydrops and intrauterine fetal demises between 28 and 34 weeks. So in the ongoing pregnancy, that was a 6th pregnancy, she presented for a dating scan at 8 weeks. and then followed by a 12-week scan where she was screen negative for Down syndrome. So here we have a woman who's Rh negative, ICT positive with a previous bad obstetric history. Now, what do we do? This is basically, we have to have a multidisciplinary team approach involving the obstetrician, fetal medicine specialist, the pathologist, and the neonatologist, because obviously with the history of previous 4 neonatal deaths, there's obviously a criteria that this pregnancy will warrant an intrauterine transfusion. So now what do we follow up with this woman with? Is it a titers or MCA PSV? We just now heard Dr. Malti speaking about titers. Here in this particular case, I would not be going for titers because we know about her bad obstetric history. So I will ideally follow this pregnancy up with a middle cerebral artery peak systolic velocity every 2 weeks. And depending on the trend of the peak systolic velocity, I might follow her up more closely. So this is a small video showing how we do the middle cerebral artery Doppler. We get into the BPD plane, we apply the color box, reduce the size of the color blocks, and then identify the middle cerebral artery at its origin and place the power Doppler about the sample gate would be 2 millimeters. And then we obtain the waveforms. And then the machine automatically calculates the peak systolic velocity and the PI. So this is how we obtain the middle cerebral artery. Now, the most important point in this Doppler is that the angle of inclination of the ultrasound beam should be perpendicular to the vessel. So if you look here, the pulse sample is exactly on the vessel. If you go at an angle, then it will give pseudo values and it might be falsely elevated. So we should make sure that the technique is right. Okay, now this particular woman, we have an ICT positive test. So we have to keep following her up with the middle cerebral artery peak systolic velocity. If the MCA PSV is greater than 1.5 moms, in general, I'm saying, if the pregnancy is less than 34 weeks, then we obviously do an intrauterine transfusion. And if the peak systolic velocity is greater than 1.5 moms and the pregnancy is greater than 34 weeks, then we plan to deliver the baby. So now this woman was on close follow-up. So middle cerebral artery peak systolic velocity, we generally follow up from 18 weeks. Now there are cases with the fetal anemia presenting very early, that is prior to 18 weeks. So in those cases, if there are symptoms of fetal anemia, obviously we cannot monitor with middle cerebral artery Doppler. So if at all a treatment is warranted at that point, then what we do is we do an intraperitoneal intrauterine transfusion. So now this particular case, she had come at 19 weeks. Her fetal biometry was okay. And if you look at the middle cerebral artery, umbilical artery was okay. If you look at the middle cerebral artery Doppler, the peak systolic velocity was 38 and it had already reached 1.55 moms. So there was evidence of fetal anemia in this case at 19 weeks itself. So this is the graph showing that the MCA PSV is greater than 1.5 moms. So the criteria for intrauterine transfusion is that MCA PSV should be greater than or equal to 1.5 moms. Now we also have to exclude false positive results. So we have to keep repeating the values, take the best value. And also if there is a doubt, you can always call her back in 1 or 2 days and repeat the middle cerebral artery and then decide on an intrauterine transfusion. So like I said, it is done in IUT is done in case of fetal anemia where the fetus is not mature enough to be delivered. It is done as an outpatient procedure. So the main criteria for an IUT is we have to prepare the blood. Now, how do we prepare the blood before we transfuse it to the fetus? It should be an adult O negative blood. It should be freshly collected within 24 hours. It should be CMV negative, HIV, hepatitis B and C negative, and it should be subjected to leukodepletion. We remove all the WBCs by filtration, and then it has to be tightly packed. We have to specifically tell the lab that we want a very high hematocrit of 80 to 85%. And we also have to, though it is all leukodepleted and infection negative, still we irradiate and then only transfuse it to the baby. So the volume of blood to be transfused will depend upon the gestational age of the fetus. And also on the donor hematocrit and the fetal hematocrit. Now, the aim of the intrauterine transfusion is to raise the fetal hematocrit by 35 to 40% in early mid-trimester and 45 to 50 in the late mid-trimester. And we have a formula for calculating the volume to be transfused. So generally, how do we do? It is an outpatient procedure. So the access could be either an umbilical vein at the placental insertion site, or if the placenta is posterior, then we go to the portal vein and do the intrauterine transfusion. So if we go into the fetus, then we obviously immobilize the fetus with vecuronium. If it is the placental insertion site, many prefer not to immobilize the fetus, but some do, because when the fetus actively moves, then it might be a hindrance to the transfusion. So we have already prepared the blood, then we insert the needle, and once we insert, first few drops we discard because it can be the maternal blood from the placenta, and then we after discarding, we then take a few drops and then send it to the lab for workup, especially the fetal blood group, and then the hematocrit and the CBCs and everything else, LFDs and everything. So it is important at this point to note that we should document the fetal blood group at this point, because once we transfuse blood, so when the baby is born, when we do a blood group, the baby will show only the blood group of the blood that was transfused. So it will easily take 6 months for the baby to show its native blood group. So ideally, we have to document the baby's blood group at the first intrauterine transfusion. So then we would have already determined the amount of blood to be transfused. Then we slowly start transfusing. Actually, we require 3 people, one person with the needle and ultrasound probe, the other person on the opposite side to push blood, and the third person to calculate the volume, because once we draw the blood, we have to send it across to the lab. We have to quickly obtain the fetal hematocrit, and based on that only, we will be knowing how much of blood we need to transfuse. So all 3 should be very well versed in this procedure. So after we transfuse about 5 ml to 10 ml per minute. Once the transfusion is over, then before removing the needle, we just push few drops of saline, and then again we draw the blood and document the final hematocrit of the baby. So then we remove the needle, and the patient is discharged with antibiotics and tocolytics if need be. So this patient presented at 20 weeks. She did have an intrauterine transfusion. She was asked to come back after two days, and then her MCA-PSV increased from 1.5 moms to 1.7 moms. So when the IUT was done, prior to that, the fetal hematocrit was 8.8. The fetal hemoglobin was only 2 grams per deciliter, and the fetal blood group was O positive. After IUT, once we did the middle cerebral artery Doppler, it had fallen from a peak systolic velocity of 45 to 22, that is 0.8 moms, and then the fetal anemia was instantaneously treated. So she was on close follow-up. Now this is the picture. If you look at this, you can just see the middle cerebral artery just glowing up. So now, why do we get an increased peak in the middle cerebral artery in fetal anemia? This is because of high cardiac output status. So there's more blood flow to the brain, and also the blood viscosity is very low, and therefore we get an increased peak systolic velocity in the middle cerebral artery. Now this picture is a post-transfusion picture. If you see, the peak is so short and stunted. So the peak systolic velocity has normalized post-transfusion. So this particular lady had 5 transfusions. So first one was at 19 weeks, 6 days. So the red line is 1.5 moms mark. And if you see this first at 19 weeks, it was well above, it was at 1.7 moms. After transfusion, it immediately dropped down to normal levels. And then we were able to follow up this pregnancy and push her to about 5 weeks. So again, at 25 weeks, fetal anemia set in, we transfused, the MCA-PSV dropped down. And this time around, we were able to push her only to about 3.5 weeks. At 28 weeks, 4 days, again, there was fetal anemia, and again a transfusion. And then again at 30 weeks, and then 32 weeks. So if you look at the graph, as the gestational age advanced, the frequency of transfusion also increased, and there was more hemolysis. So this is a tabular column of the summary of all the 5 transfusions. So the volume transfused increased from 30 ml to 90 ml at 32 weeks across the gestation. And in all transfusions, post-transfusion, the MCA-PSV moms came down below 1.5 moms. We also need to remember that once one transfusion is done, the middle cerebral artery may not be exactly very sensitive in identifying fetal anemia, but definitely it does help. So we have to bear that point in mind. So she went into preterm labor between 33 and 34 weeks. She was delivered by cesarean section. It was a baby girl, 1.8 kg, was in neonatal care for 10 days, required one exchange transfusion after birth, and was discharged as a well baby. This baby is 7 years old now. So treatment is required as regards to MCA-PSV. Treatment is that is an RH isoimmunized pregnancy with ICT positive after birth. If you're supposing you keep following up the pregnancy, there's no, and the MCA-PSV moms is well within 1.5 moms, there's no fetal anemia. Only a portion of the babies with in this group will require treatment after birth, and that is only about 15% of the fetuses. Now we also have to remember that MCA-PSV identifies severe anemia requiring transfusion, but it does not exclude the presence of mild or moderate anemia that may require neonatal treatment. So if you still keep following up the pregnancy, we have to be in sync with the neonatologist. And we also have to pre-warn the patient that there's no anemia as of now, but the baby might require exchange transfusion post-birth. So this is the mother who had the transfusion, and this is the child. And it was an absolute pleasure meeting this child who had come 2 years ago. So that was a very rosy picture. And now we move on to case number 2, Mrs. PA. She was a gravida 3. She had one child and she had one miscarriage. She was referred at 25 weeks, 4 days. If you look at the biometry for 25 weeks, the biometry was all above the 90th centile. And if you look at the Doppler, the middle cerebral artery Doppler was showing 1.79 moms. So obviously with an RH negative gravida with an ICT positive and an MCA-PSV of 1.8, I'm going to suspect fetal anemia. So if you look at the ultrasound pictures, so there was polyhydramnios, there was placentomegaly, there was fetal ascites, there was also pericardial effusion and cardiomegaly. So these are the Doppler pictures. So immediately we arranged for an intrauterine transfusion. So the baby was transfused with blood the next day. The follow-up was that the baby was well post-transfusion, but within 24 hours of our follow-up, the baby succumbed and there was an IUFT. Now the point in presenting this case was because of the high drops, the baby didn't pull through. Whenever we give a transfusion in the setting of a high drops, it is really a high risk case and may not always have a very good outcome. So the idea in sharing this case is we should identify all these cases prior to high drop sets in, and then there is this place of middle cerebral artery Doppler to identify fetal anemia before high drop sets in. So this was the reason to present this case. Unfortunately, it was very sad. And so moving on to case number 3. So this is Mrs. LR, 35 years, gravida 5, para 4 with no living children. So she had lost all her babies at 8 months. And she gave one history of intrauterine transfusion at her 3rd pregnancy. Unfortunately, babies didn't pull through. And she has had 2 previous cesarean sections. And when she came to us, it was her 5th pregnancy. So she was referred at 16 weeks. At 16 weeks, her biometry was okay, but her one of her right uterine arteries showed high resistance flow, and there was also a low PAPA, and she was already on aspirin and heparin. So we explained that she would require frequent monitoring, and if we identify fetal anemia, that she might require transfusion. So then she was followed up closely. When she came at 20 weeks, her biometry was okay, but now both the uterine arteries showed high resistance. The other fetal Doppler was normal. She was under very close surveillance. And then she came at 26 weeks. in between, she had close follow-up with her obstetrician. So when she came at 26 weeks, this was the picture. So umbilical artery showed a PI of 1.8. There was very high resistance flow. And the middle cerebral artery Doppler was normal at that point with a bilateral high resistance in the uterine arteries. So obviously there was uteroplacental insufficiency. Now she was closely followed up. And then when she came at 27 weeks and 1 day, so her biometry had fallen down. If you look at the graph, the umbilical artery still shot up very much. The PI went up very high and the MCA PI started declining. There were signs of uteroplacental insufficiency with cerebral redistribution. Now, this is an RH negative gravida with ICT positive test. Thankfully, her MCA PS peak systolic velocity behaved well and it never rose up to 1.5 moms. But it was unfortunate that we were facing a situation wherein we had to deliver the baby, because at 27 weeks, this was a Doppler findings. At 26 weeks, there was high resistance. We were able to push her only by about 8 days, and the umbilical artery started showing reversal of flow. The ductus venosus was still normal, but middle cerebral artery showed cerebral redistribution. Probably if we had to follow up this case with the ductus venosus Doppler, we probably could have pushed this pregnancy by 2 or 3 days more before the ductus venosus changes had set in. But both the obstetrician and the patient never wanted to take a risk. And then the outcome was that this baby was delivered by cesarean section, weighing 750 grams, was in NICU for 2 months, and the baby is a well baby at 1.5 kg. So the perspective of presenting this case was, despite being an RH negative, the other complication of uteroplacental insufficiency had set in, and therefore we have to look at other complications as well in an RH negative gravida. So now these are my 3 case presentations. I also would like to share that apart from indirect Coombs test, there is an option of finding the baby's blood group by cell-free fetal DNA. It can be done sometime around 12 weeks or about 16 weeks, just like how we do a screening for Down syndrome. But this is not yet widely available in India. And last I heard was it is very, very expensive. But we are slowly moving towards it. And if we are able to identify the fetal blood group using this technique, that would be really very useful. So my key take-home messages are RH sensitized women. Teamwork will definitely work very well. We have to keep following them up very closely, identify them before hydrop sets in, and then do the needful, because just like RH immunization is preventable, it is also very much treatable. Thank you very much.
Thank you, Sudha, for the very, very nice case presentations and also very clear explanations for all the steps that you have done. Fantastic, actually. We are, in fact, proud that Trichy has 2 great fetal medicine specialists, Dr. Malti Prasad and Dr. Sudha. So we are really proud of both of you working in this fetal medicine unit. I think I just have 1 or 2 questions. Suppose you have a baby complicated by IUGR, and how do you go about this MCA flow thing? For some other reason, the baby has IUGR. So is there something else by which you monitor?
MC, we do the PI of the MC.
PI of? Malti?
Yeah. I think if it's a plain IUGR, RH positive, we look at the MCA for pulsatility index, look at the CPR ratio. Anything less than 5th centile will be suggestive of redistribution. But we don't take that into consideration to decide to delivery. We follow the patient, look for every week we follow up and maybe try to deliver at 37 to 38. So it's all done in centile. If you have an MCA PI, we do the centile, do the CPR ratio. Anything less than 5th centile, we call it as brain sparing, which shows that the baby is redistributing blood to the vital organs in response to the fetal hypoxia due to IUGR. Of course, you have to look at the umbilical artery and the ductus venosus also.
My question is both IUGR and in an RH negative woman.
Okay. So RH negative. negative, I think you have to keep following up. In this particular case, luckily the PSV did not go up.
Yes.
But obviously, to identify IUGR, obviously you will have a fall in the biometry, AC or an estimated fetal weight less than the 10th centile, and your umbilical artery would be showing signs. So in that way, you would definitely be able to identify IUGR. But per se, there is a difference between early and late IUGR. In an early IUGR, you use the CPR ratio, and in a late IUGR, more than the ratio, you use the centiles to deliver. So similarly, ductus venosus Doppler also, in the early gestation, it is more of use. In the late gestation, the baby can deteriorate just very fast, that you will not even have time for you to identify when the DV deteriorates. So that's the difference between early and late IUGR. RH negative with IUGR, your umbilical artery Doppler will definitely serve as a index to identify, to differentiate between fetal anemia and IUGR.
So umbilical anti-Doppler will be almost normal in.
Sometimes it can be normal.
It can be normal in RH negative, right?
Yeah.
If there is no IUGR, obviously it will always be normal.
Okay, fine.
I just wanted to add, as Dr. Sudha said, we have to catch them young. We have to catch them at the point before they develop hydrops. See, once they develop hydrops, the risk of perinatal mortality is going to be very high. And in spite of transfusions, we're likely to have an IUD. See, as far as what we have seen that when you do a IUT for a fetus with hydrops, we've seen more of intrauterine death, say about 2 or 3 weeks later. And we had a patient who was a 5th gravida, and previous 3 miscarriages at 5 months, anti-D not given. And the 4th pregnancy was immune hydrops, and she terminated. So when she came for preconceptual counseling, I said, you have to come we have to come for very close monitoring. And she came for an NT. NT was normal. We asked her to do an ICT titer. She did not do an ICT titer. And we said, you need to be followed up from 16 to 17 weeks of gestation, every 2 weeks for PSA-MCA. She didn't land up. She came at 20 weeks with full-blown immune hydrops. And thankfully, the patient is lucky. The placenta was anterior. The access to the umbilical vein was neatly done. As Dr. Sudha said, it has to be done with a lot of expertise. You should have good assistants around. You will be able to push the blood without moving the needle. We place a 3-way. So that once the needle is inside, the blood goes smoothly through 3-way. We aspirate and we start injecting. So the needle does not move. If the needle moves, you're likely to puncture the umbilical vein and cause cord hematoma. So this patient had the first transfusion at 20 weeks of gestation, and the peak systolic velocity, actually after 2 weeks later, the hydrops disappeared, but still the PSV is rising, and it was about 1.6. And we did a second transfusion at around 26 weeks and third at 28 weeks. After the third transfusion, patient went in for preterm labor, which was an accepted complication, and she delivered in a medical college hospital, thankfully, where they did an exchange transfusion, and the baby is doing absolutely fine. Baby is weighing around 2 kgs and baby is fine. And one more thing, you need to work with a team of neonatologists. After you have done a 3 or 4 transfusions, the baby is going to test negative. So the neonatologist will call and tell you, it is not immune hydrops, it's O negative. And when you have a cord, when you do a transfusion, you do a cord blood for blood group and reasons typing. So when I frantically told him that it's not negative, it's positive, because I did a group and this thing before the transfusion. Then I told him, wait for 3 months and then recheck the blood group. And after 3 months, the baby showed the original group of B positive. So literally it was a big fight between me and the neonatologist. I had to give him a lot of literature that the baby, because we have transfused the entire blood, the baby is likely to show negative. So it does not mean that it was a non-immune hydrops. It was an immune hydrops, because we usually check the cord blood for blood group RH typing. So it's a learning curve. So as we keep doing, we start learning and new things, and which we can share with our other colleagues also. So as I said, hydrops, the mortality is going to be high, and always catch them young. Start monitoring from 16 to 17 weeks. So the once the fetus shows anemia, when you do the transfusion, you can easily carry the pregnancy till about 34 weeks of gestation. And all the babies which we have picked up fetal anemia at around 20 weeks, we have safely delivered at 34 weeks, and none of them required exchange transfusion. But the fetuses which have went in for hydrops, 2 or 3 babies required an exchange transfusion. So it's always better that we catch them young and start monitoring very early in pregnancy, if the patient is willing. Some of them come from far off, they're unable to come. So all these hazards do occur, but we have to tell them the right thing to do. Sudha, that was a wonderful presentation.
Thank you.
Yes, presentation.
So postnatal transfusion will again be O negative.
Yeah. It will be O negative.
Will be O negative.
Me and Dr. Sendil used to have a big argument running to about half an hour. He said, no, it is not hydrops. I said, it is hydrops, it is positive. Then I had to show him the report. He said, it's still negative. After 3 months, I told him to recheck the blood. It was B positive. So that's a confusion which occurs between the primary physician and we and the neonatologist. So we have to emphasize that it is still an immune hydrops and they have to recheck the blood after 3 to 6 months. So the baby will show the original blood group.
Nice.
Okay.
Very nice. Have you had any instances where you had to advise termination?
Termination, you can advise, but in spite of, generally we don't ask for termination because when we have facilities for intrauterine transfusion, but if the patient is, one of the patient had hydrops at around 18 weeks and patient did not want to have intrauterine transfusion, she opted for termination and she terminated. Generally we don't do, but try to push the pregnancy, but most of them would have delivered at around 32 or 33 weeks and they're all doing fine. I think we had 2 IUDs after transfusion, after the 3rd transfusion. So as already said, maybe it was in a volume overload or the baby was, destroying too many RBCs. So we had 2 IUDs over, I think, 15, 20 cases.
So your regular screening starts from 16 weeks, is it?
16 weeks.
MCA. And
Yeah.
Once in 2 weeks,
Yes, 2 weeks.
you ask them to come. Once you do a transfusion, it becomes weekly surveillance, is it?
Yeah, post-transfusion, no, the hematocrit falls by 1 per day. So based on that, the post-transfusion hematocrit is always studied. So based on the post-transfusion hematocrit, we assess when we will she requires a second transfusion. Accordingly, we tell her to come every week. So the judgment of the second transfusion is made based on the post-transfusion hematocrit. Because if it is, if your hematocrit is 40, say 50, it falls by 1 per day. Over 10 days, it's dropped to 40. May require a second transfusion. And after post-transfusion, I think Sudha would agree that the peak systolic velocity will not be of much value. But still, there is a lot of studies saying that should you fix it at 1.5 or should you fix it at 1.6 or 1.7? But literature still says that you fix it at 1.5. So anything more than 1.5, we would consider a retransfusion.
So you will still use MOMs for recurrent transfusion also?
We have no option. We do the MOM and then we get the, we have a judgment of the fallen hematocrit. And based on that, on the MOM, we decide on the next transfusion. But we don't do it at less than 2 weeks. Generally, it's over 2 weeks.
See, what I find is generally when there's fetal anemia, you will always have polyhydramnios also.
Yeah.
So that is another clue that this, apart from the MCA PSP, that this baby is going into anemia.
The tricuspid regurgitation, polyhydramnios, they're all even saying that.
Tricuspid, when cardiac overload at the extreme, when the baby is in the verge of becoming hydropic.
We had one patient where we could not, the placenta was posterior, the umbilical vein could not be reached at all. And the baby was moving too much in spite of giving a pancreonum on the fetal thigh. And we had to transfuse into the cardiac. We did a cardiac transfusion. And actually, baby did well. The baby went up to around 30 or 32 weeks and delivered at 32 weeks. So the last option.
I have seen one intracardia at UK.
Yeah, there was no option because baby was moving too much. And it was we thought we were going to injure the umbilical vein. So in such cases, you can do a cardiac, you can do an intraperitoneal also.
Yeah, intraperitoneal mostly prior to 18 weeks when the access to the umbilical, when the vein is too thin. So then the RBCs get absorbed by the lymphatics at 16 to 18 weeks, and then that's how you tide over, and then you can follow it up with an intrauterine transfusion through an umbilical vein.
So fantastic discussion, fantastic inputs from both of you. So many take-home points. The floor is open for questions. Audience, you can unmute and ask any questions you have, or you want to discuss some case. Any questions from the audience?
Good evening, madam. This is Dr. Vinoda.
Yeah, please speak up, Dr. Vinoda.
First pregnancy for a patient for RH negative mother. Her first pregnancy was terminated at 8 weeks for missed abortion, and anti-D was given post-abortive period. Now she is pregnant for the second time. And when should we do her ICT?
Ideally at the booking visit.
Booking. If she's a sensitized pregnancy at booking and primary gravida every 4 weeks, or if she's sensitized already every 2 weeks till about 28 weeks, it's booking. It should be done at booking.
Booking, she's ICT negative, madam. And can we give her anti in the 28 weeks? Prophylactic
Keep repeating your ICTs, because fetal-maternal hemorrhage can occur at any point in the pregnancy, and the risk is more towards the 3rd trimester. So once ICT negative at the booking does not mean that this woman will not become sensitized in pregnancy. So every 4 weeks you keep repeating the ICT, and at 28 weeks, if she is still ICT negative, then you can go ahead and give the anti-D between 28 and 32 weeks. Prophylaxis.
For all pregnancies, should we repeat ICT at every 4 weeks?
Every 4 weeks, all pregnancies. If she's a sensitized, say for example, previous 3 miscarriages, anti-D not given, every 2 weeks you have to do.
Okay.
A non-sensitized pregnancy for a primary gravida, that's every 4 weeks.
I would differ slightly here, because if she is ICT positive, then there's no point in repeating ICTs every 2 weeks. It is worthwhile to do a middle cerebral artery so that you pick up anemia early.
Yeah, once ICT is positive, the option is peak systolic velocity of MC.
And for this patient, already anti-D was given for missed abortion. MTP was done for missed abortion, anti-D was given. After 3 months of abortion, she got pregnant, and booking visit itself, ICT is negative. So we need to repeat ICT at every 4 weeks. Is it, madam?
Every 4 weeks, yes, every 4 weeks.
Probably if not at 12 weeks, you can still repeat it at 16 weeks and see what it is like.
Thank you, madam.
Thank you.
Suppose it's borderline, you're not sure. Do you repeat ICT or do you go by MCA?
Borderline.
I take ICT positive as positive, irrespective of titers, because even with low titers, there is a chance that the baby can develop anemia. So my opinion is that we should follow up once ICT positive, irrespective of the titers. MCA Doppler is mandatory.
Any more questions from the audience? Anybody wants to unmute and ask questions? So can we wind up?
Ma'am?
Yeah, Dr. Vanati.
Yes, ma'am. Without ICT positive, will you follow up with the MCA Doppler, ma'am?
No. ICT, once ICT is positive, then you don't have to keep repeating the ICT titers. You can follow the pregnancy up with a middle cerebral artery Doppler.
Okay. Okay. Thank you.
Otherwise, if the patient has had a previous history suggestive of hemolytic disease of the newborn confirmed, then you can start straight away with MCA, right?
Yes.
ICT.
Yeah.
Okay.
Any more questions? Anybody has doubts or any more questions? Sorry.
Thank you, Deepa.
I think we'll call it a day.
Ma'am, thank you, Deepa ma'am and Malati ma'am, for giving us an opportunity to participate in this platform. And once again, thank you, Sudha ma'am and Prabha ma'am, for your wonderful presentation, ma'am. So, ma'am, on behalf of BSA, I would like to invite my zonal manager to have a few words, ma'am. Lalit sir.
Thank you, sir.
Lalit sir.
Thank you very much. I think it's been a very, very nice discussion. Thank you, Dr. Sudha, Dr. Malti, and Dr. Prabha for the fantastic presentation and discussion as well. Who is joining us, Mr. Srinivas?
No, ma'am. My zonal was there. Now he has left, ma'am. So once again, thank you, ma'am, for giving us an opportunity to serve. But we learned the new things, ma'am. Especially the case studies presented by Sudha, ma'am, was nice, ma'am. Thank you, ma'am.
Thank you.
Sure.
Yeah, before we call off, I would like to make a small announcement. Day after tomorrow, that is on 20th, we have a Naipunya program. This is by Foxy. This is you all must have heard of Thai Nalam project, which we did, TRIOGS did along with Safe Motherhood Committee to reduce the maternal mortality. This is by Foxy itself, Foxy's pet project of Naipunya. This is basic intrapartum, postnatal and postpartum care that all the nurses and paramedical workers need to know about. So day after tomorrow, we are having another program. I request all our members to join us, all the clinicians to join us, and also all the healthcare workers. Please spread the message. All the healthcare workers, midwives, and people who are involved in deliveries. It's going to be a very simple presentations by some of our members, TRIOGS members. Will be really enlightening presentations by everyone. So I request all the members to log in, and also encourage all your healthcare workers, nurses to log in and be benefited by this. Eventually, we will also circulate the modules to everyone so that the doctors can train their nurses also in their nursing homes. So I will send the invite and the Zoom link today or tomorrow to everybody. So a humble request for everyone to make use of this. This is a project by Foxy itself. We have a question on the chat box by Dr. Priya Vasanti. How to monitor after prophylaxis, anti-D prophylaxis with anti-D? Is ICT positive after anti-D? Anybody can take it, Sudha?
Anti-D means RH prophylaxis. First of all, you should only check ICT and then give the prophylaxis. If she has turned out to be positive, then this prophylaxis is not going to work, and you would still monitor her like any other sensitized pregnancy with a middle cerebellary Doppler.
Yeah. So I think we'll now wind up a fantastic session. Thank you, everyone. Thank you, all the delegates for joining us. And thank you, BSV. I think they should be happy that we had a wonderful discussion. Thank you so much, Mr. Suresh, Mr. Srinivasa Raghavan, and team BSV. Thank you so much.
Thank you, ma'am. Thank you, ma'am. Thank you, ma'am.
Happy day to everyone.
Thank you.
Meet you day after tomorrow in Naipunya. Thank you.